Okay, so back to, all right, sorry about that. Share computer sound, pause recording. All right, I think we are recording. Okay, good. Um, so gestational age, meaning what week are they born? Are they born at 37, 38, 39 weeks? And you can actually plot, you would plot their birth weight, or if you were looking at length or head circumference, you would plot those against their gestational age. And then this tells you, how does that compare to other babies born at the same week? Are they smaller than, average to, or larger than other babies born at that same week? And from that information, you can categorize them as small for gestational age, appropriate for gestational age, or large for gestational age. So this just gives another way of looking at their size at birth. And using these categories, you can also classify them into risks, just like you would when looking at birth weight. So low birth weight and gestational age, um, size don't always align, which is important to note. So, for example, here is a chart looking at a baby's weight in grams and then the completed weeks of gestation when they were born. So, if we look at a 35-week gestational age, which would be here on the chart, 2,200 grams. So, if we estimate about 2,200 grams at 35 weeks, we would put us between the 10th and the 50th percentiles. Um, 2,200 grams. So it's above the 10th percentile. We're seeing that. So according to gestational age, this weight is appropriate at 2,200 grams. So compared to other babies born at 35 weeks, that this baby would be considered appropriate for gestational age. But, based on the weight categories, we know that there's still low birth weight, and low birth weight still has its own increased risks. Um, so we would still want to carefully nutritionally monitor that infant. So growth charts, you just saw your first one, are really important during infancy. The Centers for Disease Control and Prevention and the World Health Organization have growth charts that are relatively easy to use once you learn them. And we'll learn more about growth charts. We'll do actual plotting during the infant nutrition part 3. But just to introduce you for them. So here we see weight for age. You can also measure the length for their age, their weight for length, and you have a head circumference. And you may have heard of wellness visits when throughout childhood, children go for what are called wellness visits. And at wellness visits, these measures will be assessed at each one. And they're all measures that are taken with simple anthropometric measuring. And I'd like to introduce you to the Apgar scoring system, because when babies are born, you often hear, well, what's its Apgar score? And this might be more relevant, less to registered dietitians working in the hospitals, but certainly just important to know, because if a little baby has, or if a baby has a lower Apgar score, that could be taken into consideration, perhaps putting them at risk of feeding developmental delays and so forth in the future. It's out of 10 points. More than 7 is normal. And as soon as a baby is born, the Apgar is assessed at 1 in 5 minutes. Here's what it stands for: activity, so a baby's muscle tone, their pulse; grimace, which is their reflex; the appearance, which is their skin color; and their respiration. So higher the points, the better. Um, if they're very active, if their pulse is over 100, if they have a prompt response to stimulation, if their appearance is pink, and they have a vigorous cry, that would all have them score a 10 on APGAR. And then having a 0, which would be of concern, would be absent activity and absent pulse, having more floppy rather than responding to stimulus if their skin is blue, which could of course indicate lack of oxygen, and if they're not breathing, all those which could warrant a trip to the NICU for further assessment. So this is just an indicator of a baby's health and um, health outcomes and fit physical status at their birth. So, newborn and infant growth assessment measures include gestational age, birth weight, length, head circumference, and the Apgar score. Normal physical growth and development, the rate and progression of early growth is a major risk factor for development of certain chronic diseases. So we assess birth weight, which typically doubles within the first 6 months of age and triples by 12 months. So we like to see if a baby, say, is born at 8 pounds, by 6 months, that baby should be up to 16 pounds. Birth length typically increases by 50% during the first year. And then after the first year, growth velocity decreases until they reach this huge adolescent growth spurt. It doesn't mean they're not growing, they're growing. They're just growing at a more constant rate without the sharp linear increase. So we really see these drastic growth spurts during infancy and then again in adolescence. The first 4 to 6 months of life require more energy and protein per unit of body weight than any other time to support this growth. Calorie and protein needs, however, do decrease as growth rate slows. So there's ebbs and flows in nutritional needs, and this is similar throughout childhood. During times of growth, demands are higher. During times of plateaus, needs decrease. That doesn't mean they're low or not there. Of course, they still need to have energy and protein and fat intake, but they're not as high as they are during these rapid growths, and children's eating patterns will change accordingly. So if a child, well, we're in infancy right now, although you'll still see in an infancy too, a child, let's say a breastfeeding baby, they might want to feed more frequently during periods of growth. And then they'll go back to feeding on their normal schedule in between their growth spurts. And you'll see that in children too. It's common for parents to say, my child will eat anything and everything for 3 days, and then for 2 weeks, it seems like they don't want to eat anything. That's them cycling through growth spurts. And that behavior we'll talk about a little bit later is totally normal. And in addition to macronutrients, vitamin and mineral needs are greater during certain periods of growth and development. Appropriate growth, such as weight and length, are traditionally used as the main criteria for nutritional adequacy. And what does nutritional adequacy look like? From birth to 6 months, the calories per kilogram per day are about 108, and the protein is 1.52 grams per kilograms per day. Keep in mind that from birth to 6 months, we are doubling our birth weight, right? So that's a really rapid period. From 7 to 12 months, we're not doubling. You're doing half that because you're going to triple from birth to 1 year. So the calories and protein needs are a little bit lower here at 98 calories per kilogram per day and 1.2 grams per kilogram per day protein. Do be familiar with these numbers. These are important to know. There's also equations for calculating energy needs of infants. Also be familiar with these equations. We'll go over them in class. Here is a practice question. Please take the time on your own. We would have done this in class to do this and complete the equation yourself. So for protein needs, it's again 1.52 grams per kilogram of body weight, and from 7 to 12 months, it's 1.2 grams per kilograms. Infants who are breastfed or who consume appropriate amounts of infant formula, they will obtain adequate protein through the breast milk or through the infant formula. Formulas are manufactured specifically to meet protein needs when given in the right quantities. For fat needs, breast milk and formula provide essential fatty acids, a concentrated source of energy, and they are formulated to facilitate fat-soluble vitamin absorption. Fat contributes approximately half calories in breast milk and formula, so you'll see different types of fats used in different types of formulas when we do our workshop. Infants use fats as supply energy to the liver, brain, and muscles, including the heart. So fat is certainly important. How do we ensure adequate intake? Well, if they're breastfeeding, a baby should have about 8 to 12 feedings per day in the beginning. They're feeding every 1.5 to 3 hours during the first few weeks of life. And thereafter, they'll gradually drop down, and usually towards the second half of breastfeeding, so 6 to 12 months, about 4 to 6 feedings per day becomes the consistent pattern. It's important a mother nurses on her first one breast first, finish it, so empty that breast, and then offer the other breast if the baby is still full. And if they're not full at that time, then the breast that they didn't feed on at the first feeding should be offered first at the next feeding to make sure that side gets adequately drained as well. Similarly, if a baby's drinking formula, 8 to 12 feedings per day in the beginning too is common, and that will be about 1 to 2 ounces at first. Then the ounces will gradually increase around 6 to 12 months. Usually babies are taking in about 4 to 6 ounces in a bottle, a couple times, 4 to 6 times per day. Feedings for breastfeeding and formula do gradually increase the time in between feedings. And with that, the amount. So moms can feed less throughout the day because the babies can take it in more as their stomachs grow. There are critical periods which are fixed periods of time in which certain behaviors emerge, and these are necessary for sequential learning of skills. If a critical period is missed, there might be difficulty later on. So infant development is closely related with infant nutrition. Just some terms include reflex. This is an automatic response triggered by a specific stimulus. There's brooding reflex, where an infant turns head toward the cheek that is touched. And that one's really important in the beginning if they are, well, breast or bottle feeding. That's how a baby can find a nipple, whether the breast or the bottle. And the suckle reflex too, which causes the tongue to move forward and backwards so the baby can suck. I really like this table that's in the textbook that shows major reflexes, the name of it, the response, and the significance, such as the palmar. A baby grasps an object placed in the palm of his or her hand. This is a precursor to voluntary grasping. Why do we need to grasp? We need to grasp foods, right? When a baby is old enough for finger foods, usually around 7 or 8, 9 months, you'll see this develop. They can start grasping food and self-feeding, which is wonderful because they're developing some independence. So you can look through this chart on your own and be familiar with these major reflexes and what their significance is. So for motor development, the ability to control voluntary muscle movement, development is top down. Controls of head are first, and then the lower legs become last. So you often hear, is the baby holding their head up? Is the baby sitting up using that core strength? And those are all signs that a baby is getting ready to eat solid foods around 5 or 6 months. Let's see, muscle development also progresses from top down as well as central, so the core to peripheral to the extremities. And all of this, again, influences the ability to self-feed, as well as their energy expended. The more muscle control they have, the more development they have, the more they're moving, right? So they are expending more energy. So this diagram is also really fun to look at because it shows how the infant developments motor-wise throughout 0 to 15 months. So you can see them going from a newborn. At some point, they can lay in the beginning tummy and begin to lift their head up. Around 3 months, they might start rolling over. Usually around 4 months, they can sit with support. And by 5 to 6 months, sit up by themselves, and should be sitting up fully by 7 months. So in the beginning, we talked about missing key milestones. This is an example. So if a baby's really not sitting up by 7 months, that may be a flag to have their gross motor skills assessed to see if everything's okay, if they're developmenting normally. The baby can't sit up by themselves. If you think about we eat, food needs to go down our esophagus. So if a baby doesn't have good head control, that could mean their esophagus muscles are weak, and they may not be able to eat foods like a otherwise normal developing baby can. So these are all important for feeding. And then by 8, 9 months, a baby is usually standing. Usually by 10 months, they're crawling. By 11 months, they can walk with a hand. By 12 months, they're pulling up. By 13 months, they're climbing up the stairs. So time to get the baby gates. And around 14, 15 months, most are walking on their own. There are factors that impact cognitive development. Severe and acute malnutrition. We need, for example, fatty acids to support brain development. So chronic undernutrition, iron deficiency, anemia is related with impaired cognition. Iodine deficiency can be associated with thyroid issues, which we need for growth and development. There's also a variety of environmental interactions. Digestive system development, again, is really important as well. And this begins in the womb. The fetus swallows amniotic fluid, which stimulates intestinal maturation and growth. At birth, the healthy newborn can digest fats, protein, and simple sugars, which is pretty amazing if you think about it. Common problems we do see include GERD, diarrhea, and constipation. GERD is treated differently, but depending on different pediatricians and their schools of thoughts, some prescribe medicines, some provide behavioral adaptations or physical adaptations to try. So GERD's actually an interesting area. And then there's factors that impact the rate of food through the colon. This includes osmolarity. So when we look at the formulas, we'll talk a little bit about osmolarity. Foods are liquids. The colon bacteria, so the gut microbiota, which is an emerging field in research, as well as body water and fluid balance. So new parents must learn the cues of hunger and satiety, infant temperament, and how to respond to cues. Progression to solid food is based on motor development. There's loss of tongue thrust. They can move their tongue side to side. They can communicate satiety, ability to sit up and hold head unassisted. They're interested in table food, and then looking at the doubling of birth weight as well. And here's a video that you can watch on your own on hunger cues that's interesting, and it might link to other interesting videos on hunger food as well. So let's talk about progression to solids in class and weaning to cup after we do formula, because we'll do formulas and then we'll do neonatal, and then we will move from infants into toddlers. So we can talk about solids and weaning then. But I do want to talk about, let's start with contraindicated foods for infants. So before 1 year of age, you should avoid honey. Why? The foodborne endless botulism. Babies' immune systems, even if they are breastfeeding, aren't good at fighting off botulism. So it's recommended to avoid honey. Any choking pieces, such as hot dogs. If you can give hot dogs, but you need to chop them up carefully. Avoid hard candies, avoid whole nuts, whole grapes, sticky foods, and hard raw fruits or vegetables, which should be softened. And other than honey, these are all choking hazards. Other food considerations is sanitation, especially if using baby formula. We want to be really careful not to contaminate the baby formula and use sanitary measures. When starting solids, if you're giving foods that need to be heated or reheated, you want to avoid foods that are too hot, because babies aren't good at communicating that this is too hot. Also avoiding sugary beverages and foods, and especially giving anything other than milk or formula, breast milk or formula in a bottle is a big no-no. The only exception would be water, but it's encouraged to give water in a straw cup, which we'll talk about later. Just some supplements for breastfed infants include vitamin D, because breast milk doesn't contain adequate amounts of vitamin D, as well as iron, starting at 4 months of age. And then there's iron recommendations are higher if a baby is preterm. So for formulas, it is recommended to exclusively breastfeed for 6 months and continue to 1 year, but for various reasons, formula is needed. And formulas now, we're fortunate because they are manufactured to closely resemble human milk, but a lot of um, things still can't be replicated. So you shouldn't give cow's milk before age 1, because it's associated with increased risk of iron deficiency. And because milk has low iron availability, this can actually result in a GI blood loss. So that's one reason cow's milk is not recommended in infancy. Um, there are special infant formulas available that will alter carbohydrate, protein, or fat composition. Babies with different medical conditions might need different formulas. The general types of formulas are cow's milk-based formulas, soy-based, protein hydrolysates, elemental or amino acid based. If a baby has a protein hypersensitivity, they can't break down a whole like whey or casein protein. So baby formulas have them broken down already, but these tend to be a little bit more expensive. So are usually held off recommending only when needed. And then in the infant formula workshop, we'll learn about basic formula preparations, including powders, ready to feeds where there's no mixing required. And these are often used in the clinical setting, as well as liquid concentrates. So more to come on infant formulas. Let's see, if you have any questions, let me know. Let me see. So we'll do our infant formula lab, and that slide needs to be updated. Continue working on your short review paper. Module 2 is posted to Moodle, and this should say test. Test 2 is Wednesday, March 25th. All right. Thank you for listening. If you have questions, please send me an email, and hopefully I see you all on Wednesday. Stay healthy. Wash your hands. All right. See you soon. Bye.